This video demonstrates how to use the Avanos gastrointestinal anchor set with safety Pexi T-fasteners that are included in the Avanos introducer kit for gastrostomy feeding tubes. Note, while several visualization methods can be used to initially place a G-tube, the process for using the Avanos gastrointestinal anchor set with safety Pexi T-fasteners is the same regardless of method. The Avanos introducer kit for gastrostomy feeding tubes is intended to affix the stomach to the anterior abdominal wall, facilitating primary placement of the Avanos Mick and Mickey brand enteral feeding tubes. Note, the safety Pexi device contains 3O-biosin synthetic absorbable sutures that in non-clinical studies retained tensile strength to approximately 75% of USP and EP minimum knot strength at 14 days and approximately 40% at 21 days post-implantation. Absorption of the suture is essentially complete within 90 to 110 days. Warnings. The kinetics of gastric wall adhesion to the anterior abdominal wall relative to suture absorption must be considered prior to using the safety Pexi device when a compromised healing response is anticipated, especially when adhesion of the gastric wall to the anterior abdominal wall is not expected within 14 days. T-fasteners may migrate and be retained in the gastric mucosa, abdominal musculature, or subcutaneous tissues, and in rare circumstances have exited through the skin adjacent to the stoma site. If performing an early replacement gastrostomy within the first few weeks after initial safety Pexi placement, verify that the adhesion of the gastric wall to the interior abdominal wall is established and maintained. Consider use of an additional T-fastener to ensure proper early replacement of gastrostomy. The suture locks may pose a choking hazard. Caution: the safety Pexi needle point is sharp. Suggested placement procedure. Place the patient in a supine position. Prep and sedate the patient according to clinical protocol. Ensure that the left lobe of the liver is not over the fundus or the body of the stomach. Identification of the medial edge of the liver by CT scan or ultrasound may be helpful. Glucagon 0.5 to 1.0 mg IV may be administered to diminish gastric peristalsis. Insufflate the stomach with air using a nasogastric catheter until adequate distension is achieved. Choose a catheter insertion site in the left subcostal region, preferably over the lateral aspect or lateral to the rectus abdominal muscle and directly over the body of the stomach toward the greater curvature. Using endoscopy, fluoroscopy, or laparoscopy, choose a location that allows as direct a needle path as possible. Prep and drape according to facility protocol. Place a skin mark at the tube insertion site. Define the gastropexy pattern by placing 3 skin marks equidistant from the tube insertion site and in a triangular configuration. It is recommended to perform a 3-point gastropexy that approximates an equilateral triangle to help ensure secure and uniform attachment of the gastric wall to the anterior abdominal wall. Allow adequate distance, approximately 2 centimeters, between the insertion site and safety Pexi placement, to prevent interference of the anchor set and feeding tube balloon once inflated. Locally anesthetize the skin and peritoneum at each puncture site. Carefully remove the preloaded safety Pexi device from the protective sheath and maintain slight tension on the trailing suture, noting that the suture is held to the needle by a retaining snap on the side of the needle hub. Attach a Luer slip syringe containing 1 to 2 milliliters of sterile water or saline to the needle hub. Under fluoroscopic, endoscopic, or laparoscopic guidance, insert the preloaded safety Pexi slotted needle with a single sharp thrust through one of the marked corners of the triangle until it is within the gastric lumen. The simultaneous return of air into the syringe and visualization confirms correct intragastric position. Contrast may be injected upon air return to visualize gastric folds and confirm intraluminal position. After confirmation of correct position, remove the syringe from the device. Release the suture strand. Bend the locking tab on the needle hub. Firmly push the inner hub into the outer hub until the locking mechanism clicks into place. This will dislodge the T-bar from the end of the needle and lock the inner stylet into position. Withdraw the needle while continuing to gently pull the T-bar until it is flush against the gastric mucosa. Avoid having the T-bar exert excessive tension onto the gastric mucosa. Discard the needle according to facility protocol. Gently slide the suture lock down to the skin surface of the abdominal wall. A small hemostat may be clamped above the suture lock to temporarily hold it in place. Caution: do not place the hemostat below the suture lock or between the suture lock and the abdominal wall, as damage to the suture may occur. Repeat the procedure until all 3 anchor sets have been inserted in the corners of the triangle. After the 3 safety PEXI devices are properly positioned, gently pull on the sutures to oppose the stomach to the anterior abdominal wall, avoiding exerting excessive tension on the sutures. Close the suture lock with a supplied hemostat until an audible click is heard, securing the suture. Any excess suture length may be cut and removed. Note, for additional suture security, a knot may be tied in the suture strand at the surface of the suture lock. Inspect the stoma and gastropexy sites daily and assess for signs of infection, including redness, irritation, edema, swelling, tenderness, warmth, rashes, purulent or gastrointestinal drainage. Assess for any signs of pain, pressure, or discomfort. Routine care should include cleansing of the skin around the stoma site and gastropexy sites with warm water and mild soap, followed by thorough rinsing and drying well. The sutures may be left to be absorbed, or they may be cut when deemed appropriate by the placing physician. Letting the sutures be absorbed or cutting them will allow the T-bars to pass through the gastrointestinal system. After the sutures dissolve or are cut, the suture locks may be removed and discarded. It is recommended not to cut the sutures within 2 weeks post-procedure. Note that absorption of the suture is essentially complete within 90 to 110 days.